Welcome back to the Pro PA podcast. I'm your host, Prof G, and you're tuning in to another episode of our MSK101 series, where we simplify the musculoskeletal and rheumatologic diseases from the PANCE blueprint, one condition at a time. In this episode, we'll break down Juvenile Idiopathic Arthritis, or JIA, the most common rheumatologic disease in children. We'll review high-yield facts you need to know for the boards and the clinic. Let's dive in. Did you know that children with JIA can sometimes have no joint pain at all? In some cases, their only presenting symptom is a painless swollen joint, which is why it can often go unnoticed or be confused with a sports injury. So first, let's look at the kinderpatho. What is JIA? Well, JIA is a group of autoimmune disorders that cause chronic arthritis in children under 16 years old, lasting at least 6 weeks. It's believed to involve autoimmune activation triggered by genetic and possibly environmental factors, leading to chronic synovial inflammation. There are several different subtypes, but the main ones to know are oligoarticular, which is less than 4 joints involved in the first 6 months, or polyarticular, which is greater than or equal to 5 joints involved. And you also have the systemic or still disease, which is arthritis plus systemic symptoms like fever and a rash. All right, now let's look at some of the clinical presentation. So, symptoms really vary by the subtype, but most commonly, the symptoms include joint swelling and stiffness with decreased range of motion, morning stiffness that improves with activity, limping or avoiding use of the affected limb in younger kids. And as far as systemic JIA, they also get spiking fevers, salmon colored evanescent rash, hepatosplenomegaly, and lymphadenopathy. Some unique findings can be chronic anterior uveitis, which is a complication especially in oligoarticular JIA, which is ANA positive. And remember, it may be painless, especially in younger children. All right, now let's look at the workup and diagnosis. So, the diagnosis is clinical. Arthritis, you have it in one or more of the joints, and you have it for at least 6 weeks in a child under 16 years of age. You want to exclude other causes like infection, trauma, or malignancy. Some helpful labs include ANA. It's often positive in the oligoarticular JIA. We can also get a rheumatoid factor in anti-CCP, which may be positive in a polyarticular for the RF positive subtype. An ESR and CRP are usually elevated, and imaging, an X-ray or MRI, can show joint space narrowing and synovitis. As far as the eyes, we recommend screening by slit lamp and exam every 3 months for patients at risk of uveitis. All right, now let's look at the treatment. So, first line treatment is going to be NSAIDs, and that's going to be for symptom control. You can also consider giving intraarticular steroids for those oligoarticular diseases. We also can consider disease modifying agents like methotrexate, especially for polyarticular or resistant cases. Other options include biologics like TNF inhibitors if they're unresponsive to the other methods. Something important to consider is monitor growth and development. Chronic inflammation and steroid use can affect both. All right, now let's look at the book med versus the street med. So, book med, you'll see a straightforward case of a limping child with 2 swollen knees and a positive ANA. Street med, on the other hand, the child may present with nonspecific symptoms like fatigue or subtle limping, and it may take weeks or even months before someone connects the dots and refers them to rheumatology. You'll need a high index of suspicion. All right, let's wrap up with some clinical pearls. So, most common subtype is the oligoarticular JIA. Look for uveitis, refer to ophthalmology for regular eye exams. Fever plus rash plus arthritis, think systemic JIA. Treat early to prevent joint damage and growth delays. And a positive ANA increases the risk of uveitis. All right, now that we've gone through that, let's do a few practice questions. So, question one, we have a 7-year-old girl who presents with knee swelling and morning stiffness that lasts over the past 6 weeks. She has no fever or rash. her ANA is positive. What's the most likely diagnosis? Is it A, rheumatic fever, B, juvenile idiopathic arthritis, C, systemic lupus erythematosus, or D, septic arthritis? I don't think you'll need too much time for this one. It's what we've been covering, so the answer was B, juvenile idiopathic arthritis. Remember, classic oligoarticular JIA in a young girl with a positive ANA and knee involvement, you got this one in the bag. Question 2. Which of the following is the most feared complication of oligoarticular JIA? Is it A, joint erosion, B, pericarditis, C, anterior uveitis, or D, fever recurrence? I'll give you a little time. If you said C, anterior uveitis, you are right. It can be asymptomatic and lead to vision loss, and it requires regular eye screening. All right, some final thoughts. So, JIA is more than just arthritis in kids. It's a collection of diseases that can impact a child's joints, eyes, and development if it's not caught early. Recognizing subtle presentations and following up with the right labs and referrals can make a lifelong difference. Keep it on your radar and think broadly when evaluating pediatric joint complaints. Don't forget to follow the ProPA podcast and tap that notification bell so you never miss an episode. For more visuals and walkthroughs, check out my YouTube channel, Professor GPAC. Thanks for joining me on today's MSK101 Clinical Medicine Brief. And as always, this is the ProPA podcast, where future pros in medicine are made. See you next time.